And I'm delighted to introduce our first speaker, who is Sarah Lucas, who is a healthcare analyst from the strategy unit, who will be talking about quantifying categories of potentially mitigatable hospital activity to support healthcare planning. Just can see Sarah's just joining. Thank you. And I'm going to say this to all the speakers, we are going to try and keep to time, but just a reminder for everyone, if you can post questions in the Q&A, and there is a facility to vote and upvote the ones that those questions that you're particularly interested in. But at that point, I will hand over to Sarah.
Okay, thank you. So hopefully my slides will be coming up. But yeah, today I'm going to be talking about some work that I've done alongside Anya Ferguson and Justine Wiltshire in the strategy unit, looking at potentially mitigable activity. So obviously there's this current focus on shifting care from acute hospitals into community settings. And this all assumes that there are subsets of hospital activity that can be mitigated, that can be avoided, either through greater use of existing community services or through new services. So for the New Hospitals Programme Demand and Capacity Model, the strategy unit has actually developed 92 categories of hospital activity that can be defined as potentially mitigable. And measuring the rates of this potentially mitigable activity can give us an indication of whether hospital activity is being avoided and is being moved to community services, because obviously it's not possible for us to directly measure avoided hospital activity. That's just an unknown. So with this work, we aim to inform healthcare planning through understanding the scale of potentially mitigable activity to help inform prioritisation. So what areas are there high volumes of activity that might be a good target? We also wanted to track trends to indicate whether there'd already been any shift away from hospital care, or to at least provide a baseline to compare to going forward. And also we wanted to do some comparative analysis to have a look to see, are there areas that are doing things better than others, where perhaps there's opportunities for us to learn from what they're doing. So of the 92 categories of potentially mitigable activity, we've looked at 29 of those, and those are ones that are focused on hospital inpatient activity and moving that using community services. So this activity can be divided into kind of four broad categories based on the mechanism by which we think mitigation of activity could occur. So we have a redirection and substitution group. And so this is activity where we think some of the hospital activity could be avoided by moving it to community services. It includes admissions for frail older people, ambulatory care sensitive admissions, medicines related admissions. And then we also have a prevention group. This is more public health focused, so around public health initiatives around smoking, obesity, alcohol, those kind of things. And then we have a group that are relocation and efficiencies. So that's basically virtual wards. And then our last group is efficiencies. So these are a little bit different to the other groups. The other groups, we're thinking about potentially avoiding admissions and therefore reducing bed days. However, with efficiencies, we don't think the admissions could be avoided, but what we think is that actually lengths of stay could be potentially reduced and we get a reduction in bed days for efficiencies. And there's a couple of key things that we kind of need to bear in mind with our analysis. That is that the categories are not mutually exclusive. So what it means is that somebody could have an admission that falls into an ambulatory care sensitive category, could also fall into a smoking category, and maybe also an acute respiratory category as well. So we can't just sum up the activity in total. Otherwise we'll end up with double counting. Also, what we're saying with this is not all of the activity within these categories can or should be avoided. So these are quite broad categories They include a lot of activity. Some of them are very high volumes. What we're saying is that potentially a proportion of the activity within each of these categories could be reduced. So in practice, that may say be 10% or something like that. So what we've done is we've produced an online report. My colleague Anya is going to post the link in the chat, because basically it's a really big report. There's loads of data in there, and so I can only touch on a few kind of key points today. Obviously, there's pages for each of the 29 categories of potentially mitigable activity, and there's several summary pages in that as well. So what I'd say is, if this is something you're interested in, is to go and actually have a look at the report, because there's a lot in there. It includes descriptive analysis to give you a bit of an idea about who it is that's in each of these categories. It also includes cohort overlap analysis to help understand which of these categories are overlapping and the degree of overlap between them, and also some comparative and trends analysis. And I'm just going to give you a kind of high-level overview of a few of the bits of comparative and trends analysis that we've got today. So starting off looking at trends. So nationally, hospital activity is reducing for end-of-life care. So if we look over the last 5 years, we can see that the number of admissions to hospital for end-of-life care has reduced by 23%, suggesting that there has been some shift away from hospitals, more towards caring for patients at home or in hospices. However, for a lot of the categories of activity, we're actually seeing increases. On this slide, I'm actually showing bed days. And we can see for chronic ambulatory care sensitive conditions, there's been a 19% increase in bed days in the last 5 years. For acute alcohol-related bed days, a 35% increase. And then for admissions of frail older people with high frailty risk, there's been a 10% increase in bed days. So I'm going to focus on this frail older people category and show you some of the breakdown for that. So this data is the most recent year of data that we have. So it's 2023-24. And it's looking at the variation in bed days for frail older people admissions by ICB. So this is using age and sex standardised rates per 100,000 of the population. And you can see there's considerable variability between the different ICB areas in the rates. So not only can we look at you can look in the report at what there is for the current year, but also in changes over time. So here we're showing change in hospital activity for frail older people over the last 5 years. So on the left is admissions. And you can see here that the England average, there's been about a 1% increase in admissions for frailty, but considerable variability between the ICB areas. So some areas are seeing a much larger increase, other areas are actually seeing a decrease. So here I've just highlighted Cornwall and the Isles of Scilly. They've actually had a 23% reduction in admissions over the last 5 years. If you have a look at bed days, so as I mentioned earlier, bed days have actually increased nationally by about 10%. You can see here, there's a lot more of the ICBs are seeing increases in bed days. In fact, Cornwall and the Isles of Scilly, despite having a large reduction in admissions, they actually have an 8% increase in bed days. So still below the national average, but they are seeing an increase. Although there are a few areas here, again, that have managed to decrease their bed days. So given this kind of slight difference in what we see in terms of admissions and bed days, that made us then start to think, okay, what's happening in terms of length of stay? So we have done a little bit of work within the report on length of stay as well. So on the left is a chart showing the national trends for frail older people, broken down by the different lengths of stay. So you can see for the shorter lengths of stay, so kind of the red, orange and yellow lines that are for under a week, the proportion of those for frail older people is actually falling. However, for longer lengths of stay, what we're seeing is for 1 to 2 weeks and 2 weeks plus in the blue and purple lines, we're actually seeing an increase over the last 5 years in those longer lengths of stay. And again, we've broken it down by ICB. So here you can see this time it's showing average length of stay. So the England average length of stay has increased by about 8%. But again, obviously, there's considerable variability between areas in terms of the changes that they've seen. So I should say that we focus mainly in the report on ICBs in terms of breaking it down, but we do also have data in the report at local authority level and also at provider level as well. So you can look at all of this at those levels as well. So in conclusion, some kind of high level points from the report are that we are starting to see shifts away from hospital care for some categories of potentially mitigable activity. So, for example, for end-of-life care. However, for many categories of potentially mitigable activity, hospital care is actually increasing. So, like I've shown for high frailty, chronic ambulatory care, sensitive conditions, and acute alcohol-related admissions, those in particular are increasing. We also see considerable variability between areas in terms of the rate of activity and in changes over time. And also for some activity, we are seeing these trends towards increasing lengths of stay. So obviously there is this balance there between trying to reduce admissions, but also balancing that with reductions in length of stay as well. I would say really the key take-home point is if this is something that you're interested in, is to go and have a look at the report, because there's obviously a lot more there and you can focus in on anything that you're particularly interested in. Really, it's been designed to try and help ICBs and providers to understand where there's opportunities to reduce inpatient activity and the scale of those opportunities. Also to provide an opportunity to identify those systems that are kind of higher performing, so potentially others can learn from what they might be doing. And also, we're hoping it will help inform decisions about the potential of shifting funding from acute services more into primary and community care. So thank you for listening. I'm happy to take any questions. Again, I've just popped up the link to the report. Also, the GitHub repo as well is open if you want to have a look at the code. Thank you.
That's brilliant. Thanks, Sarah. Can you hear me, Sarah?
Yeah.
Yeah, fantastic. And you've kept beautifully to time. Thank you. There was a question in the I think we just got time for probably one question. There was one question in the chat about the definition of frailty, but I think Anya has already answered that one. So we'll pick up. There was a question from David Lewis asking, sort of really interesting, sort of what other potentially avoidable areas could you suggest that people look at? I don't know whether you've sort of considered that as part of your analysis.
So obviously we've got these 29 kind of categories in here, but there are also obviously a whole other load of categories that have been developed. And I think there's probably more work on trying within these categories of trying to define them a bit more clearly. So at the moment they are very broad, and actually there is probably something about taking those and thinking, okay, maybe can we define a subset of those a bit more closely, because obviously it's only a proportion that could be reduced, and there is the risk of it getting lost a little bit in the noise if they are broad.
Brilliant, thank you. I'm afraid we probably not going to have time to take the second question, but Sarah, presumably you're around in HACA if people want to follow up with you, and obviously there's the report on the website. But it was an absolutely fascinating presentation. Thank you very much.